So, hello and welcome everyone. My name is Emma Groves and I'm the pharmacy lead for the North Eastern Yorkshire Genomic Medicine Service. And in this session today, we're going to cover a beginner's guide to pharmacogenomics and hopefully inspire you all to go on your pharmacogenomics journey after the session. So, to kick off, I thought it might be helpful just to give you a bit of background to me and how I got involved in genomics and pharmacogenomics. So, I'm a pharmacist by background and I finished my undergraduate MPharm in 2014, and then I went to work in hospital training. And my genomics journey really started when I began the MSc in genomic medicine in 2016. And that really is what got me into this space. I then went to work as an oncology specialist pharmacist and really loved that area of practice. And I did get to see pharmacogenomics used in the real world setting. Um, as part of my work in oncology, I also done independent prescribing and was involved in prescribing targeted anti-cancer treatment to patients with renal cell carcinoma. And now here we are today. I'm the pharmacy lead within the Genomic Medicine Service. So that's my journey, and I hope you all enjoy the session. So just to kick off, I thought we would do a quick round of true and false to get you thinking about pharmacogenomics. So if you can, I don't know if I can see, but if you want to put a hand up for true and false for the following statements. So question one, pharmacogenomic testing is currently available in the NHS. Yellow hands for true. Okay, I've got a few hands coming up. So if the trues want to drop their hands and okay, should we do hands up for false? Okay. Right, so we've got a bit of a mixture there. Question number two, if we take all of our yellow hands down now. So question number two, how a patient metabolizes a medicine, so that's how they break down a drug, will not change over their lifetime. Hands up for true. Hands up for false. Um, okay, so again, maybe there are some people who are unsure as well. And the third and final question is true or false. 95% of people carry at least one pharmacogenomic variant that would influence how they respond to a medicine. Hands up for true. Okay, so quite a few trues coming through, and hands up for false. Okay, so hopefully that's got you thinking a little bit about pharmacogenomics, and unfortunately you're going to have to hang on until the end to find out the answers. So in terms of this main presentation, I'm going to give you a quick background to pharmacogenomics, what it is and how it's currently being used in the NHS. We'll then think about what the future might look like for pharmacogenomics and talk about some barriers and also enablers to really bringing this into mainstream practice. And at the end, we'll signpost to some education and tools and resources to help you on your pharmacogenomics journey and get ready to take action. So, just in terms of the ongoing challenges related to medicines, we know that in England alone, there's a significant amount of money spent on prescribing of drugs. And in 22-23, approximately 19.2 billion was spent on medicines. We also know that unfortunately some patients have adverse drug reactions to medication, and sometimes that can be quite severe, with 1 in 15 hospital admissions estimated to be linked to an adverse drug reaction. So that also translates into bed occupancy of about 6%. We also know that from the literature and evidence base that common drug interventions are only effective in about 30 to 50% of people because of differences in how individuals respond to a medication. So we have lots of ongoing challenges. And the area that I'm going to talk to you about today is pharmacogenomics. And this could be used as a tool in the future and also now to help tackle some of those medicines problems that we just talked about on the first slide. So, what is pharmacogenomics? Pharmacogenomics is defined as the study of how a patient's genome, so that's their complete set of genetic material, can influence how they respond to medicines. That's both in terms of how effective a medication can be and also medicine safety. So there's a strong link with pharmacogenomics and medicine safety, and this information can help us predict patients who may suffer from side effects, and that can range from some unpleasant and less desirable side effects all the way up to side effects which are potentially life-threatening. And pharmacogenomics combines the fields of pharmacology and genomics and is all about safe, effective medicines tailored to variations in a person's genes. So I just wanted to talk you through variation in drug response. And we all know as healthcare professionals that there's variation in how patients respond to treatment. So when you give the same medicine to a different group of individuals, you'll see this spectrum of efficacy and toxicity, where some patients will have benefit and efficacy from taking a medicine and no toxicity, whereas other patients might get no benefit from taking a drug but experience toxicity. And again, that might range from unpleasant to potentially life-threatening. Now, what we would love to move to is away from the standard trial and error approach and towards a pharmacogenomics approach. And the image on the slide there is taken from the British Pharmacological Society Personalised Prescribing Report. And this is a brilliant report that outlines the potential for pharmacogenomics in the NHS. And Helen might pop a link in the chat for anyone who wants to know more about the area. But on the diagram, as you can see, we have a group of patients at the top, and the standard approach is that those patients would all be prescribed the same medicine, often aligned to clinical guidance and that one size fits all approach. And those people would vary in how they respond, and that might be linked to genetics as well as other factors. And some people may have side effects. And then what happens in the real world is patients will have their doses adjusted, or they may have their medication stopped until you get to that right medicine at the right dose for the right patient. Now, what we're aiming for and aspiring towards in the future is what we would call the pharmacogenomic approach. So a patient would have a pharmacogenomic test done, so that might be done as a saliva sample or a blood test at some point within their life. And then if we did what we call a pharmacogenomic gene panel, we would have information about multiple genes that impact response to multiple medicines, and that information would be stored on the patient's healthcare record and available for healthcare professionals who interact with that patient throughout their life. So that's the aspiration, that's what we're heading to, but it's going to be an evolution to get there. And I'm going to cover some examples of pharmacogenomics in the real world practice in this session. So we've talked about variation in drug response, but why is there variation in individuals? So there's multiple factors around variation. So things like multiple health conditions can impact why people vary in response to medicines. You know, pharmacogenomics and genomics does have an impact, demographics, environment, drug-food interactions, drug-drug interactions, renal and hepatic impairment, and of course, whether a patient actually chooses to take that medicine. So although I'm advocating for pharmacogenomics to be used as part of treatment-related decisions, it's not the only factor, and it's really important that we use this information as an additional tool within the medicines optimization toolbox, but as routine, we still need to consider the other factors such as renal and liver function, drug-drug interactions, comorbidities, etc. So I'm now going to go through how pharmacogenomics links to pharmacology, and hopefully this is familiar to a lot of you on the call. This image again is taken from the British Pharmacological Society report, and it covers the pharmacokinetics and pharmacodynamic processes of a drug. So pharmacokinetics is what the body does to the drug. So that's absorption, distribution, metabolism, excretion. And pharmacodynamics is what the drug does to the body. And a drug molecule can have on-target and off-target effects. Now, the important thing to think about here is essentially where a medication is interacting with the body, it's interacting with a protein. And that's where pharmacogenomics comes in and links to pharmacology, because those proteins, which are often enzymes, are coded for in your DNA. So there's lots of common variation in genes that impact response to medicines, and this variation is very common and affects multiple proteins. And because of this variation in how the drug interacts with proteins, you can have different effects. So in terms of adverse drug reactions, you can have what we call type A adverse drug reactions because of on-target effects from a medicine. So they might interact insufficiently with a protein, they may have an optimal effect and efficacy, or that interaction might be excessive, and that's what we call a type A adverse drug reaction. Comparably, you can have off-target adverse drug reactions, which are classed as type B, and those off-target drug interactions are linked to non-immune and immune responses. So now, although over the last decade, there's been huge evidence built up around pharmacogenomics, translation into clinical practice has been quite slow. So in terms of the evidence base, the Clinical Pharmacogenetics Implementation Consortium, which is a recognised international group who looks at the evidence base for drug-gene pairs, they have listed 26 drug-gene pairs with really strong explicit pharmacogenetic guidelines. And as we've mentioned before, a huge proportion of the population carry at least one pharmacogenomic variant. So this variation in pharmacogenes is normal within the population and very common. But the translation into practice has been slow. And on this slide there, I have examples of pharmacogenomics which is used within the NHS, and I'm going to go through a few in some case studies. Reasons for why the translation into practice has been slow is multifactorial, and it's things such as lack of access to genotyping tests. So some of this testing just isn't available in the NHS yet. Concerns around cost effectiveness, lack of confidence and knowledge around how to interpret some of these pharmacogenomic tests and make decisions if a patient does have a variant that impacts their treatment. Concerns around this being very disruptive to normal clinical pathways, and also huge challenges around informatics and how we store this pharmacogenomic data in the patient record, and also confidentiality issues. So there are some challenges that we face, and part of the work of the Genomic Medicine Service is how we can support with education to overcome some of these barriers. So that's a bit of a whistle-stop tour to pharmacogenomics, and I'm going to go through 3 examples now of pharmacogenomics linked to specific medicines. So the first example I have here is DPYD pharmacogenomic testing prior to fluoropyrimidines, and this is one of the gold standards of implementation of pharmacogenomics in the NHS, and this is one of the pharmacogenomic examples that I routinely reviewed as an oncology pharmacist. So DPD stands for dihydropyrimidine dehydrogenase. It's quite a mouthful, so I'll just use DPD. And DPD is an enzyme, and that enzyme is coded for by the DPYD gene. Now, that DPD enzyme is involved in the metabolism of really commonly used chemotherapy drugs called fluoropyrimidines, and they're prescribed for things like gastrointestinal, breast, and head and neck cancers. And the examples of those drugs are 5-fluorouracil, capecitabine, and Tegafur. Now, what we know is that some people have a deficiency in the DPD enzyme, and that means that when they're prescribed fluoropyrimidine-based chemotherapy, they can't break down those drugs, and the level of those drugs can increase in the body because they can't break them down, and then that can lead to potentially severe side effects. Deficiency in the DPD enzyme can be inherited, and variants in the DPYD gene. So DPYD pharmacogenomic testing came about because of a medicine safety issue. So in the blue boxes there, you can see that the medicine safety issue is that some patients had very specific changes in the DPYD gene that led to low enzyme levels and inability to metabolize the fluoropyrimidine-based chemotherapy. And as a consequence, they were at risk of severe and at times life-threatening toxicity. But this new pathway was introduced where we now routinely do upfront pharmacogenomic testing, and we test for 4 variants in the DPYD gene that we know are linked to low enzymatic activity. Clinicians can then use that information to inform the prescribing of the fluoropyrimidine chemotherapy agents. So if a patient did have a variant, then the patients would be offered alternative treatment or an upfront dose reduction. And this test is all about keeping patients safe. And as I said before, it really is an example of gold standard implementation, and we do close to, I think, 40,000 tests a year in England. And it's a huge success story for pharmacogenomics, but there is still work ongoing and important research required in terms of maybe expanding the variants that we test for. So we currently test for 4, but that could be expanded, and also to ensure that we are not disadvantaging patients from particular ethnic groups. So I know that sometimes pharmacogenomics and genomics can seem like a bunch of letters and numbers, and the nomenclature used in pharmacogenomics can be challenging, but once you have an example, it's easier to understand. So I just thought I'd talk you through what these genes and letter symbols mean. And on the slide there is a link to a pharmaceutical journal article if you want to know more information, which Helen will pop in the chat. So DPYD is the gene symbol. C, the C represents that there's been a change in the coding region of that gene, in the DPYD gene. The number 1679 is the nucleotide position within that gene where there's been a change. And then the T, so that's the thymine, that's the reference nucleotide, which is no longer present because it's been swapped for a guanine. So that is the nucleotide that's been substituted and now is present in the gene. Okay, so we're going to move on to another example now called mtRNR1 variants, which are associated with aminoglycoside hearing loss. So aminoglycosides are antibiotics. They're really commonly used. They've been used since the 1940s, and they're active against gram-positive and gram-negative organisms. So the drugs there are things like gentamicin, amikacin, tobramycin, streptomycin, neomycin. And the toxicity profile of aminoglycoside antibiotics is really well characterized. And it includes things like renal impairment and potentially irreversible hearing loss. And these side effects generally are linked to the dose of the drug and the length of treatment, and they can sometimes be exacerbated by liver and renal impairment. However, we know that some patients appear to have what we call a predisposition to aminoglycoside-induced hearing loss, and that's due to variation in the mitochondrial RNR1 gene. So there are case reports of even profound bilateral deafness in patients who've received um, aminoglycosides that are within the normal therapeutic range with one dose. And on the slide there, we have one of the most common variants that are linked to this adverse drug reaction. So M for mitochondrial, 1 555, A to G. And it's estimated that 1 in 500 individuals carry that genetic change. Now, genetic testing for that particular variant is listed on the National Genomic Test Directory, and we popped on there the test directory criteria. However, the challenge is that testing for this particular variant via the laboratory system can take up to 6 weeks, and we know that often antibiotics and aminoglycosides are required in an acute setting and required to be administered urgently. So to overcome this challenge, there has been research into what we call point of care testing. And I just wanted to talk a little bit about the PALO study. So again, Helen will pop a link to the paper in the chat. But the PALO clinical trial, so PALO stands for Pharmacogenetics to Avoid Hearing Loss study, was a clinical trial that was led by colleagues in the Northwest and was trialled in Liverpool and Manchester. And as part of this clinical trial, what they did is they used a point of care device called GeneDrive to do rapid pharmacogenomic testing for that common variant, the M1 555A to G in neonates. So babies who were admitted to NICU, PICU, and were likely to require aminoglycoside antibiotics were tested using the GeneDrive device. And in that trial, they did test 750 babies, and they found 3 that carried that change and were able to offer those babies alternative antibiotic treatment. So huge benefits to patients, their families, and the wider NHS. And I think this is really where we see the strength of pharmacogenomics. Now, that technology is under review via NICE, and NICE have an early value diagnostic assessment which has been published, and NICE have made some recommendations around evidence generation and further information that's required before the GeneDrive device is reviewed in a full NICE technology assessment, but really looking forward to seeing the outcome of that evidence generation work. So the third and final example that I wanted to talk to you about is clopidogrel, and the gene is CYP2C19. So clopidogrel again is a very commonly prescribed medicine, and it's administered as what we call a prodrug, so it's inactive when a patient takes that drug. It requires metabolism within the liver in order to convert clopidogrel to its active form. And one of the enzymes that's really important in this pathway is CYP2C19, and it's critical in the bioactivation so that then the clopidogrel can be active and go on to have its effect as an antiplatelet and decrease the risk of thrombus and clots. So variation in the CYP2C19 gene is important in order to predict the metabolizer status of an individual. And NICE again are actively looking at CYP2C19 genotype testing to guide clopidogrel use after ischemic stroke or transient ischemic attack. And there's a nice review. Helen, if you don't mind popping in the chat the link to those documents so you can go have a read. They're all in draft form at the moment, and we're anticipating end of July that there will be an update on this NICE diagnostic assessment. There are some information on the NICE website around the potential numbers and benefit to patients for CYP2C19 genotype testing, and it's estimated that 32% of people in the UK carry at least one what we class as decreased function or no function CYP2C19 allele. And we also know that the prevalence of these alleles are more common in the Asian population, but they can be found in patients of any ethnicity. So again, we're really looking forward to seeing the outcome of that NICE review. So I talked a little bit about pharmacogenomics and gave you some examples of where it can be used in practice. And although at the moment we're kind of looking at single drug gene pairs, the future is likely to be moving towards that pharmacogenomic gene panel where we look at multiple genes that impact response to medicines all in one go. And there is a clinical trial that is being led by colleagues in the Northwest called Progress. And it's a really exciting clinical trial. And I'm going to share a video to their patient information to give you a bit of an update on what's happening within that study and what the future could look like. So I'm going to press play. I hope you can hear that.
Medicines are commonly used in healthcare to treat and prevent disease. However, not everybody responds the same way to every medicine.
Can you hear that, Helen?
For some people, medicines will work well.
Yes, we can, yeah.
But for others, they may have harmful side effects, or the drug might not work at all. When medicines don't work as planned, people might need to see their doctor more often, or even end up in hospital with harmful side effects. This is bad for them and for the NHS. There are many reasons why a medicine might not work as planned. A person's age, their other medical issues, and other medicines all play a role. Another important reason why a medicine might not work is related to a person's genetics. The study of how genetics impacts the safety and effectiveness of a medicine is known as pharmacogenetics. By using a person's pharmacogenetic information as part of their routine healthcare, medicines can be made safer and more effective. The results could be used by your doctor or pharmacist to choose the right medicine at the right dose for you, with less trial and error. This could lead to better health outcomes for patients and could reduce pressure on the NHS. Right now, there is not much pharmacogenetic testing undertaken in the NHS. One reason for this is that in the past, the testing was very expensive and took a long time. However, genetic testing is now cheaper and quicker than it has ever been. The main issue preventing pharmacogenetic testing in the NHS now is related to how to move the test results around the NHS. Only a small number of specialist NHS laboratories can perform pharmacogenetic testing, but the test results need to be used across the NHS wherever patients are receiving care. The NHS is leading a project to overcome this challenge, working with patients and NHS staff to develop solutions to move the genetic data securely to where it's needed. One of the ways this is being looked at is through a pilot project in a small number of general practices across England. Patients who are going to be prescribed certain types of commonly used medicines will be eligible to take part. This is how the study will work. When a patient attends an appointment at their GP practice, if they are eligible, they'll be asked if they are interested in taking part. If they agree, they will give a blood or saliva sample, which will be sent to a specialist NHS laboratory for testing. The DNA from these samples will be tested for genetic changes related to how people respond to medicines. These results will be stored securely and confidentially within the NHS laboratory. It will take around 1 week for the test results to be made available to the GP and pharmacy teams. Once the results are made available, these can be used to help select the best medicines for the patient. For some people, the results will show that their originally planned medicines should work well. In other people, the results may show that a higher or lower dose or a different medicine altogether may be more appropriate for them. The patient can then collect their prescriptions from the pharmacy. Over the course of the study, the research team will monitor how this genetic information is used and how it improves the safety and effectiveness of medicines. As these results are relevant to many different medicines, these pharmacogenetic test results will be used across a person's lifetime. Because of this, Each time they need a new medication, the doctor or pharmacist will be able to use their test results to help pick the right medicine. As well as these results being made available to NHS staff, the project is working with patients, their family and carers, and the public to find out the best way for people to access their own results. This project has brought together NHS staff, scientists, and patients from around the country. And if successful, it could lead to the use of pharmacogenetics in everyday clinical practice. Using pharmacogenetic information in the NHS could personalise medicines for patients, saving money for the NHS and improving patients' lives.
Okay, so I hope you enjoyed that video, and we will pop in the chat links to more details around the Progress clinical trial, which is currently active. It sites within the Northwest, and they are rolling out across England this year. So watch this space. So although there's huge excitement around pharmacogenetics and the potential, there are some considerations around implementation that we've popped on the slide there. So consideration around, consideration around things like the strength of evidence and the availability of clinical guidelines, thinking about which patient groups to test and also when to test them within their pathway. Do you do this upfront at birth, or should we be testing patients when they're taking multiple medicines or when they're prescribed a trigger drug? Importantly, availability of other treatment for patients. So if you have a pharmacogenomic variant, that means you're unlikely to respond to a particular drug. Then what are the other options for you, and what does that mean to the treatment pathway? Healthcare professional knowledge and acceptance of pharmacogenomics. So it's really important that we educate and upskill colleagues across the NHS. Cost effectiveness of pharmacogenomics is very important, and it is something that I anticipate will be looked at for many years to come to make sure that what we're implementing is cost effective. Multifactorial nature of drug response. So we spoke about at the beginning of the session that pharmacogenomics is not a golden bullet, but is a useful tool to inform decision making alongside other factors. Ethnicity and applicability. So this is also a very important consideration. So genetic research and pharmacogenetic research to date has largely been based around European ancestry populations. And we need to think about, when we implement this testing, we need to consider the diversity of the populations and the patients that we treat, and to ensure that we're not exacerbating health and racial inequalities. And there will strongly likely be a component of further research in this area to make sure that we're not widening health inequity. Testing and technology infrastructure. So as pharmacogenomics moves at pace, and we move from doing single drug gene pairs onto large pharmacogenomic gene panels, this is going to require changes in testing technology, but also investment in infrastructure of our laboratories. So anticipate that that might be an important part of pharmacogenomics at scale in the NHS. And finally, and this could be, again, a very important area to consider, is the integration of genomics and pharmacogenomics data across the healthcare system and within the patient healthcare records. So as you saw in the video from Progress, one of the elements that they're specifically looking at is how you move pharmacogenomic results around the healthcare system. And this will be key. So we need to make sure that when a test is done, that it's visible in the patient record, and that healthcare professionals can use this information. And we will also need some support around decision making and clinical decision support to support prescribers and healthcare professionals use this information appropriately. So just to finish off, I'm going to share with you some tools and resources that will help with pharmacogenomics education, and also, if it crops up in clinical practice, where to look. So my top tool, and if this is the key thing that you take away from this presentation, is the availability of genomic notes for clinicians, also known as GNotes. And Helen will pop a link in the chat to GNotes, which is designed for busy healthcare professionals to help them make the right decision about genomics within patients' clinical pathways. So if you go onto the GeneNotes website, there's a section called In the Clinic, and you'll see that there's a variety of different modules. And in the left-hand side there on the print screen, you can see pharmacogenomics. And when you click on that button, it will take you through to the In the Clinic section where there is multiple examples of patients presenting with pharmacogenomic results. And if you click on one of the in the clinic presentations, it will take you through to an example. So for example, this one is presentation of a patient requiring mavacamten for treatment of hypertrophic cardiomyopathy. So we know that some patients who are CYP2C19 poor metabolizers have a higher exposure to mavacamten, increasing risk of side effects. So I would really recommend having a look at that resource and knowing that it's available if something crops up in practice too. Other tools and resources. So as always, first and foremost, there is information around pharmacogenomics in the BNF, which we usually use for medication dosing, and also in product information such as the summary of product characteristics. If you want to learn more about pharmacogenomics, then there is the Medicines Learning Portal. This educational tool was designed for pharmacists, but it's pharmacists and pharmacy technicians, but you should be able to access it for free, no matter what professional background you're from, and it's a really good resource. If you have more time and want to go into more depth, there is funded MSc level modules in pharmacogenomics funded by the Genomics Education Programme as part of their MSc. And we know now that there is funding confirmed for 24-25. So if this is something you're interested in doing, then definitely take a look. The UK Pharmacogenetics and Stratified Medicine Network also provides educational resources, and they have annual conferences which they record and then pop the videos onto YouTube. So there's lots of sessions around pharmacogenetics from expert speakers. If you're a pharmacist or pharmacy technician, then the Centre for Pharmacy Postgraduate Education also provide a 2-hour e-learning on an introduction to genomics and pharmacy, which you may find useful. And finally, if you are wondering which pharmacogenomic tests are available and commissioned in England, then the National Genomic Test Directory is the place to go, and it'll tell you which tests are commissioned and the eligibility criteria for patients. So we're getting towards the end of the presentation now, and we'll go through the true and false answers, see how many you got correct. So pharmacogenomic testing is currently available in the NHS. The answer to that is true. There are some specific examples, but they are limited at the moment, but we anticipate that they will grow in the coming years. Question number 2, how a patient metabolizes a medicine will not change over their lifetime. This one is false. So although your germline DNA, so the DNA you inherit from your mum and dad, and that impacts your pharmacogenomics, that will not change throughout your lifetime. However, other factors will change, such as comorbidities, renal function, your liver function will change, and that will overall impact how you respond to a medicine. Question number 3, over 95% of people carry at least one pharmacogenomic variant that would influence how they respond to medicine. That is true. Pharmacogenomic variation is very common within the population, and that's one of the reasons that it has huge potential for safe, effective medicines use. So, to summarize, pharmacogenomics is the study of how a patient's genome influences how they respond to medicines, both in terms of effectiveness and safety. It's an evolving area and a real example of how we're mainstreaming genomics in the NHS. And it's anticipated that the availability of pharmacogenomic testing will increase in the coming years. Pharmacogenomic testing will absolutely require a team effort, and education and training of healthcare professionals is key. So we really hope that you've enjoyed this session, and if you scan the QR code and complete the feedback survey, that really helps us make sure that the sessions that are delivered are relevant and what you would like. So if you click on that link, you can complete the feedback form, and you will also be emailed a certificate of attendance for your CPD. And final, last little plug, I know that you heard me mention earlier that there is a module in pharmacogenomics and stratified healthcare as part of the Masters in Genomic Medicine via the Genomics Education Programme. But there are other modules available, and there's funding confirmed for CPD modules, which are standalone modules that you can then build into postgraduate qualifications. So you can build the CPD modules into a certificate, then diploma, and then potentially MSc. So that is the end of the session, and a huge thank you to everyone for listening, and I'm happy to take any questions.
Thank you so much, Emma. That was absolutely an absolute brilliant roundup of pharmacogenomics. As somebody that's worked alongside you, I've learnt lots from that. So thank you so much. As we've been going along, there's been some great questions that have been posted into the chat. So what I will just say is I know sometimes people can have difficulty accessing chats, particularly in different trusts. So what we will do is when we circulate round the link to say that this has been recorded and it's gone live on our website, we'll also include the links within that. So if you have missed anything, if you give us a week or so, then that should be circulated around. So first question is, what is the best resource for the available tests in a particular trust or region in any particular specialty?
So if it's in terms of understanding what's available and what's commissioned, then that's the National Genomic Test Directory.
Yeah.
That's there to make sure that's equitable across England. So in terms of where to go to know what's funded, then that would be the best port of call. In terms of education, we know that everyone's super busy, and I think GeneNotes is a really good educational tool to use as part of training, education, or as a practitioner if you're in practice and something crops up that you need to know the most up-to-date information about pharmacogenomics, and that's the resource I would.
Thanks, Emma. And also the National Test Directory is constantly being monitored and updated. So as and when more of these tests become available, it'll be the test directory that they'll sit on. So if it's on the test directory, then it's commissioned centrally. Okay. I'm just having a look at what the question, just looking at them in between all the resources. Carolyn Hardy commented that this is great. I will get it added to our Trust Cancer Hub. I don't know, Carolyn, did you want to come on and say anything more about that?
Hi, thank you, Emma. That was excellent. That was so informative. I think as a cancer educator, and we're quite new in the region, I think it's really important that we kind of get on board with this in terms of developing resource. So I think I'll send out an invite if possible to meet with you separately, so that you can guide me on how best we can do that, if that's okay.
Yep, absolutely. And I think again, it's difficult to go through all of the examples, but there are other genes that are linked to chemotherapy drugs and have medicine safety links. So for trying to anticipate what might be coming down the track, then we can talk about that.
Thank you so much.
Thank you. Thanks. And Dave, I can see you've got your hand up there, but I'll just go through the questions in the chat if that's all right, just to keep it in order. That'd be great. Thank you. Patrick has asked, is there any data for which cancers a pharmacogenomic test has been inserted in a pathway, and how many days this adds to the treatment?
That's a really good question. And I guess in terms of pharmacogenetics and your germline DNA, DPYD is the standout example. And we have done some work around turnaround time and embedding that within the pathway. And the test results for that are usually turned around within a maximum of 5 days. So it does not disrupt the pathway because there are other factors at play. I guess if you're thinking about oncology, there are other genetic components that are within the tumour. So tumour mutations that you can then target a drug to, and there are ongoing bits of work around genomic testing within cancer and how that fits within the pathway. And I think this is going to be, in terms of oncology and cancer treatment, it's going to be a long-term conversation around how we can embed it for the best impact for patients.
Yeah, thanks, Emma. And also just to add to that, the thanks, Patrick, is that also the testing that often is being done for pharmacogenomics is looking for specific changes, and often genetic testing, when you know what you're looking for, is much quicker. So whereas you might hear reports, you know, in other areas of genetic testing of things taking months, potentially even years, with tests like this, where I always think of it, it's like looking for a spelling mistake. If you know what page of the book it's on, if you know which paragraph and which sentence it's in, it's a lot quicker than looking for it through a whole book. So testing shouldn't be in these kind of scenarios where it's relating to treatment, shouldn't be influential on in a negative way. So Helen Seymour has asked, are POC genetic tests as accurate as lab-based sequencing? So POC, point of care.
That is a very good question, and I think it will depend on the technology and the device that is used. And I'm probably not qualified to answer that, but there's certainly notes within the NICE diagnostic assessments for the point of care testing with MT-RNR1 that notes making sure that the accuracy and the validity of the result is appropriate. So I think I think it will depend on the device.
Yeah, and as you explained in your presentation, Emma, the only example in the NHS research setting is obviously the PALO study, and in that scenario, it isn't, you know, if you did receive a result that was to flag that you did carry this variant, it would be a different antibiotic you're prescribed. It wouldn't be detrimental to your treatment in receiving one of those, even if it was a false positive.
Yeah, exactly. So false positives are probably less impactful than false negatives.
Yeah.
And in the PALO study and with the gene drive, the recommendations are that if you do have a positive patient, you should confirm that via the laboratory technology as well.
Yeah, great. Thank you, Emma. So there was a question from Karen about getting the contact details of the people that had developed the progress study video, and I put a little comment to say that on the link that I'd posted to that video, it does give contact details at the bottom, but if there's any issue, please feel free to come back to our team, and I've put our team's email there. Helen Seymour has asked, how should clinicians respond to patients who have had a private test which indicates that there may be some issue with their RX medicines?
Oh, thank you for that really easy question, Helen. I think this is a difficult one. In terms of signposting to other resources, the Royal College of GPs does have a statement around genomics more broadly, and patients presenting with results that are classed as direct to consumer, which we can share a link to. I'm aware that that is being updated by a group of colleagues to include pharmacogenomics and to have recommendations. I think this is a difficult area, and ultimately it will be up to the clinicians responsible for that patient care to assess whether this is a useful tool. But I would strongly say to consider the robustness of the test that's been undertaken and the validity of the result, because if the result isn't valid, it hasn't been done by a robust technology, then you can't rely on the outcome. So it's a tricky one.
Yeah, thanks for that, which is hence my earlier question, which was about are the point of care tests, which I think, because I understand that you can now get sort of lateral flow type test things, by various direct-to-consumer companies. So, you know, as a clinician, what do you do if you get presented with something that's come from that sort of testing situation?
If your employer or company have advice on private testing, you could or just private diagnostic testing in general, that might be something to consider. And I know Helen, who's a genetic counsellor by background, would say that clinical genetics would not routinely review direct-to-consumer results.
Yeah.
Okay.
So we always encourage it. So if people are wanting help in terms of interpreting their report, we encourage them to go back to their providers and seek that through them. And we wouldn't trust any result that wasn't produced within the NHS. So we might consider repeating that test to see if we can confirm that result. Yeah, we wouldn't encourage that. Yeah. Okay, thank you. But I put that position statement in. I put a link in. Should you want to have a little bit more of a look on that? So the next one, again, another question from Patrick. Could you give me any idea how long a test takes, assuming no waiting? So I think we've kind of addressed that already. I think in another earlier question.
So every pathway will be slightly different, Patrick. DPYD takes about 5 days. The MT-RNL1 can take up to 6 weeks. The work that's been done within the progress study there, hoping to return results back within a week. So ideally for pharmacogenetics, you need these results rapidly because prescribing decisions happen fairly quickly too. So I think the model we need to work towards is results that are there within a week that is clinically useful to prescribers and patients. But every pathway might have its own quirks.
Great, thank you.
Could I follow up on that, please? Does it actually take a whole 5 weeks to do one test? Is that how long it has to be on the go?
Not necessarily, but on the National Test Directory, it outlines some of the timeframes as well for reporting. So that's how the laboratory aligns their timescales.
Yeah, but that assumes queues and things like that, I presume. I was wondering if you just were going to do a test, how long that would take without just one-off situation.
Yeah, I think it very much depends on the test, Patrick. So there are lots of different types of genetic tests. So if you're just looking, so for example, in a predictive scenario where you know what you're looking for, it can still take about a week. So 4 to 6 weeks is the guidance that we're given as genetic counsellors. If you're looking at maybe a panel of genes, then you might be looking at a series of months. If you're looking at everything, the ideal turnaround is 12 weeks, but many labs across the NHS are still struggling to meet that. So it can take up to a year or two, not just to do the physical testing, but actually to do the reporting, because there's so much obviously that you see when you do that wide scale reporting. Yeah. Okay.
Thank you.
That's right. Next question is, do you have any further information regards the yellow card biobank that I could use in YC training?
A very good note, so I will find it in a second, but the MHRA, so a lot of these pharmacogenomic variants are linked to patient safety, and the MHRA have teamed up with Genomics England, and they're looking at a biobank. And I think they've got a few specific examples where I believe allopurinol is one of them, where patients have an adverse drug reaction. You can involve them in the biobank where they'll have sequencing done, and then that can inform evidence generation around which variants are relevant to these particular ADRs. So it's a very good piece of work, and I will go online now and see if I can find the link for you. That's
great. Thanks, Emma. And Carolyn has said thanks for the session and about meeting up separately. The link to the evaluation has been asked for, and I've posted that again below. So it's difficult to put a QR code in the meeting chat, but I've put the link in, so hopefully that'll be easier for you to access. somebody's commented about NHS Scotland's Scottish Strategic Network of Genomic Medicine and the Genomic Test Directory. So that is to say that the test directory that we've referenced is for England and will be different for the devolved nations. Again, some thanks for the session and a request for the slides to be shared. And again, if you're happy with the Emma, we can maybe tag that into when the video is available. And again, comment. Thank you, Emma. I'm a healthcare science student working in genomics, and this webinar has been super informative and has given great insight into the topic. And another thank you. And also somebody's commented that would also be interested to see more research in their findings, and I think that's definitely key. So I'm conscious that we're coming up to time and that we've still got people with their hands raised. So I'm just going to go to raised hands. It's fantastic to see so many questions. It's lovely to see. So Charlotte, I think you've had your hand raised, but I think it might be from the beginning of the true and false. So yeah, it's gone down. Thanks, Charlotte. So Dave, can we have your question, please?
Yes, very quickly, mindful of time. Thank you so much, Emma. Absolutely brilliant presentation. I have one thank you and two observations, not really questions, but observations for all of us to take away. Firstly, thank you. I am currently the chair of the Patient Public Views panel for the Northwest of England, so it's an absolute pleasure to see that you gave the progress study animation videos such a wide coverage. Thank you again. I and our working group were heavily involved in rewriting the whole of that script because the original script wasn't on message. So for those who were interested in the animation video, do give Helen a shout. We'll be more than happy to talk to you more about that. And I mention that because that is a great example of where the patient and public voice can have a real impact in changing the direction of front-facing patient information. For anybody who's interested in getting involved, working with your patient public views panel, please get involved in the North Eastern Yorkshire because you can make a difference. First observation, as the progress study rolls out from the Northwest out to the rest of the country, and we certainly hope it will because we're getting some great results, feedback so far from our regional work in the GPs. And as the linkages between the different NHS departments links up with hospitals, GPs, etc., you're going to have a really vibrant information network and data source there that needs to be protected. I think security is a big issue here. So on the one hand, you've got security and making sure that information is secure within the NHS ecosystem so that nobody outside of it gets access to this information, like insurance companies, big pharma who shouldn't be getting access to this and those that should, and how we manage that. That's a big consideration here. Security versus sharing that information. It's a big problem. And the second observation I just wanted to make was that as this technology evolves and develops, where does that leave the existing community of disabled people? I'm not just talking about people who are profoundly deaf or born deaf or deafened, but other groups such as my own, people with a visual impairment. As the payload device and other similar devices come online, I think it presents a real big set of ethical questions about where this takes us in terms of disability and long-term health conditions, because of course this technology is going to help to spot problems, issues, concerns which may lead to a disability or long-term health condition, stopping that from occurring. But then where does that leave us in terms of changing society and changing the views of society toward the existing community of disabled people or people with long-term health conditions? No answers, but something for us all to think about. Thank you.
Thanks, Dave. Did you want to comment there, Emma, or?
Yeah, no, I think Dave,
that's okay.
Yeah.
I think just we're dead on 1 o'clock, but just to agree with you, Dave, and obviously genetics almost goes hand in hand with ethics. So as a specialty in medicine, we have always had a mindful eye on the ethics of the work that we do, and I would hope that that continues into the future, even as it is mainstreamed. So yeah, but thank you for raising those issues. So thank you so much, everybody, for taking part, and also thank you so much for your questions. It's been really lovely to hear that active discussion. As I say, we will be in touch with the recorded link and also with those resources. Any questions at all that you don't feel like we've had chance to answer, then please feel free just to contact us at that generic hello email, and we'll make sure that the question gets to the right person. Thanks, everyone.